Welcome to Kanski lecture series, and this is the Eyelids part 9, and in this part we are going to discuss about the ptosis. So basically the ptosis is the drooping of the eyelid, and the normal position of the eyelid, the position of the eyelid is lower than the normal. Ptosis classification. Ptosis is an abnormally low position of the upper lid which may be congenital or acquired. So there are two types of ptosis. Number one is congenital, another one is acquired. Neurogenic ptosis is caused by an innovational defect such as third nerve paralysis and Horner syndrome. So these are some things, the cause of the ptosis. Sometimes it is neurogenic, means that a nerve supplies to the levator muscle is affected or the molar muscle is affected. For example, in Horner syndrome, when the sympathetic innervation is defected, there will be the lower position of the eyelid because the molar muscle is not getting innervated. And in third nerve paralysis, basically it is like the levator muscle is not getting innervated, so there will be the ptosis in that case. So these are the neurogenic causes of the ptosis. So what is myogenic? Myogenic mean that there are nerve supply is good, but there are something muscle are weak, and muscles get weak. Most important causes myasthenia gravis, myotonic dystrophy, and external ophthalmoplegia. Myogenic ptosis is caused by the myopathy of the levator muscle itself or by the impairment of the transmission of the impulses at the neuromuscular junction. Neuromyopathic acquired myogenic ptosis occur in myasthenia gravis, myotonic dystrophy, and progressive external ophthalmoplegia. So these are all the conditions that we will discuss in the neuro-ophthalmology chapter. Aponeurotic or involutional ptosis is caused by the defect in the levator aponeurosis. Basically, the aponeurotic ptosis is the age related, when there will be the weakness of the levator muscles and levator aponeurosis is weakened. Mechanical ptosis is caused by the gravitational effect of the mass or scarring. So these are all the causes of ptosis. A is showing neurogenic ptosis, B is myogenic, C is showing aponeurotic, and D is mechanical, which is caused by the neurofibroma. So clinical evaluation is very important. Why it is very important? Because we usually treat the ptosis on the basis of the severity and the cause of the ptosis. So it is very important to evaluate the ptosis clinically. The age of onset of ptosis and duration will distinguish congenital from acquired cases. If the history is ambiguous, old photographs may be helpful. It is also important to inquire about the symptoms of possible underlying systemic disease such as associated diplopia, variability of the ptosis during the day, and excessive fatigue. So history is sometimes important. You must differentiate that whether it is a congenital ptosis or acquired ptosis. And you can also take the history for any kind of myasthenia history, like the diplopia, variability of the ptosis during days, and fatigue. Pseudotosis. So what is the pseudotosis? Pseudotosis is basically the eye, its lid itself is not in the uh, lower than normal, but it is basically the false impression of ptosis. And why it occurs? The false impression of ptosis may be caused by the following. Lack of support of the lid by the globe may be due to an orbital volume deficit associated with an artificial eye, microphthalmos, phthisis bulbi, or enophthalmos. So you know that eye has a volume, and if that volume is adequate, the eyelid positions are at the normal position. But if there is a deficiency in the eye volume, like the eye is slightly enophthalmos, it is slightly smaller, eye is slightly smaller, or it is the phthisis bulbi eye, or even the patient is having an artificial eye, the lids are not a problem in this case. It is basically the deficiency in the orbital volume that is causing the impression of the ptosis. So you can see figure 2.4 8a, and you can see the ptosis, left artificial eye ptosis. So you can see that there is a ptosis, but you can see that it is a prosthetic eye which is causing the ptosis of the eye. Contralateral lid retraction, which is detected by comparing the levels of the upper lid. Remember that margin of the upper lid normally covers the superior 2 mm of the cornea. So sometimes when the other eyelid is slightly retracted, like you can see that slightly retracted, then it gives the false impression of the ptosis in the other eye. So to differentiate is that basically the upper lid margin is normally covering the 2 mm of the superior part of the cornea. So if the lid is retracted, you will know that a sclera will be shown, and you can identify that it is a contralateral lid retraction which is causing the impression of ptosis. Ipsilateral hypotropia causes pseudostosis because the upper lid follows the globe downwards. It disappears when the hypotropic eye assumes fixation on covering the normal eye. So in case of like a med or monocular deficiency, monocular elevation deficiency, so like what happens is the eye is having a basically a hypotropia, like, so these are the eyes. So the other one eye is having a fixation and other is having a because it is a ptotic eye, the reflex will come upward. So because of this, the upper lid follows the hypertropic eye, so it will give the impression of the ptosis. So but whenever the you cover this eye and this hypotropic eye takes a fixation, the ptosis also uh, mm, normalize. So this is called the false ptosis or pseudotosis. So in this case you can see B is showing the contralateral lid retraction which is causing so you know that this eyelid is retracted a little bit, and you can see that it is slightly above than a normal uh, margin, and this is a normal eye, but it is giving the impression of the ptosis. And this is an eye, C is an ipsilateral hypotropia which disappears on covering the normal left eye. So this is giving the impression this is also ptosis due to hypotropia. Brotosis is due to excessive skin on the brow or seventh nerve palsy, which is diagnosed by manually elevating the eyebrow. Dermatoclasis, overhanging skin on the upper lids, may be mistaken for ptosis but may also cause mechanical ptosis. So basically when there is an excessive skin on the eyebrows, it can also induce ptosis. So these are called brotosis. And dermatoclasis is basically there is an overhanging of the skin on the upper lid which can be mistaken for ptosis, like this. So measurement of the ptosis, which is very important because you have to evaluate the ptosis for the treatment. Marginal reflex distance is the distance between the upper lid and the margin and the cornea, a reflection of the pen torch held by the examiner on which the patient fixate. The normal measurement is 4 to 5 millimeter. So what is a marginal reflex distance? You know, so this is a figure that is showing us the MRD. MRD is A is showing the distance between the reflex to the upper lid, and it is A is showing normal, B is showing mild ptosis, C is showing moderate, and D is showing the severe ptosis. And you can see 2.51 is showing the how do you measure the palpebral fissure height. It is the distance between the upper lid and the lower lid, and in the center of the pupil, and it is usually about 7 to 12 mm. And 2.52 is basically the measurement of the levator function. So A is place the thumb firmly against the brow to reduce the effect of the frontalis muscle, and ask the patient to look down. The patient then look up as far as possible, and the amount of excursion is made with the ruler. So basically, you place the thumb on the eyebrow, and then you do not let the frontal talus muscle to act, and then you ask the patient to look in the down gaze, and then you place the ruler in the at the margin of the upper lid in the down gaze, and ask the patient to look up to the roof as far as possible, and then you measure the action of the levator muscle, and this is usually normal is up to 15 millimeter. If it is 4 millimeter, it is called the poor levator function. Next is the upper lid crease. Upper lid crease is taken as the vertical distance between the lid margin and the lid crease in down gaze. In female, it is measured about 10 millimeter, and in male, 8 millimeter. Absence of the crease in a patient with congenital ptosis is the evidence of the poor levator function, whereas a high crease suggests an aponeurotic defect, usually involutional. The skin crease is also used as a guide to the initial incision and some surgical procedure. Pretarsal shows the distance between the lid margin and the skull fold with eyes in the primary position. So these are just two other things that you must know. Basically, you know that there is a when you there is a upper lid, and there is a lid crease on the upper lid as well. So in the down gaze, you measure the distance between the lid margin and the lid crease, and basically it is about 10 millimeter in female and 8 millimeter in male. And if this crease is not present, it suggests that a presence of a congenital ptosis. And if there is a high lid crease, then it is showing that there is an aponeurotic or involutional ptosis, and it is also used for the guidance in some surgical procedure. And pretarsal show is when the eyes are in primary position, the eyes are looking straight, the distance between the upper lid and the skin fold is the pretarsal show. So next is the associated signs of the ptosis, which may help us in leading to the diagnosis of the ptosis. Number one is the pupils. The pupils should be examined in order to exclude the Horner syndrome and a subtle pupil involving the third nerve palsy. The latter is an unlikely acute clinical presentation. So what happens in case of pupil? Basically, if the pupil is small, then a normal size, then it can be Horner syndrome, and if it is larger than normal, it can be due to the third nerve palsy. So that is why pupils are also examined in the ptosis. Increased innervation may flow to the levator muscle of a unilateral ptosis, particularly in up gaze. Associated increased innervation to the contralateral normal levator will result in lid retraction. The examiner should therefore manually elevate the proptotic lid, and this should be the ptotic lid instead of proptotic lid, and look for the drooping of the opposite lid. If this occurs, the patient should be warned that a surgical correction may induce a lower position in the opposite lid. So what do we do is basically, this is the lid, a lid with the ptosis, and this is of the normal. So what do you do is, that the law of same innervation is that a same type of innervation goes to the each muscle of the levator. So whenever there is a ptotic eyelid, what you do is that there will be the increased innervation to raise this ptotic lid, but it will cause the lid retraction of the other lid as well. So what you do is basically you manually elevate this ptotic lid, and when you elevate it, the other lid will go slightly down. This is called the mechanism of increased innervation. And what it will help, that you can counsel the patient that after doing the surgery on the ptotic eyelid, there may be the induction of a slight ptosis in the other eye as well. Fatigability is a test by asking the patient to look up without blinking for 30 to 60 seconds. Progressive drooping of one or both lid or an inability to maintain up gaze is suggestive of myasthenia gravis. Myasthenic ptosis may show an overshoot of the upper lid on saccade from down gaze to primary position, Kogan lid twitch, and hop on side gaze. So these are signs of the myasthenia. What you ask the patient, you ask the patient to look up in the up gaze direction for 30 seconds. If it is the increase of the ptosis of the that side of the lid, it means that it is the cause of myasthenia. uh, Other test you can do is an eye spec test, which is coming as well. Another sign is that when you do saccades movement, you know the saccades, you ask the patient to look down and then up, look from one target to another without uh, not you ask the patient to look down and then up, down and up. And when the patient do goes from down to up, there is a slight retraction of the ptotic lid, which is called the Kogan twitch sign. So in from the down gaze to the up gaze, there will be the slight retraction of the lid, and this is called the Kogan twitch sign, and this is on the saccades movement. And other thing is that hop on side gaze. Hop on side gaze is basically you ask the patient to look in the side gaze, and there will be the retraction of the ptotic lid. So this is the hop sign. Ocular motility defects, particularly in the superior rectus, must be evaluated in a patient with congenital ptosis. Correction of an ipsilateral hypertropia may improve the degree of ptosis. Deficits consistent with subtle or partial third nerve paralysis should be identified. So why ocular motility is important? Because sometimes the ptosis is associated with third nerve palsy. It can be associated with a superior rectus weakness as well. And so in that case, what you can do is you correct the superior rectus weakness first, then you correct the and there is a hypotropia, you correct the hypotropia first, then you correct the ptosis. So that is why it is important to check the ocular motility defect in the cases of ptosis. Jaw winking can be identified by asking the patient to chew and move the jaw from side to side. So when you ask the patient to chew, there will be the decrease in the ptosis. Bell's phenomena is tested by manually holding the lids open, asking the patient to try to shut the eyes and observing the upward and outward rotation of the globe. A weak Bell's phenomena carries a variable risk of post-operative exposure keratopathy, particularly following large levator resection or suspension procedure. So why Bell's phenomena is important is basically because Bell's phenomena is for the post-operative care. For example, if the patient has a poor Bell's phenomena, there can be the risk of exposure keratopathy in those patients. So that is why Bell's phenomena is important. So how do we perform it? So we ask the patient, we manually open the both eyelids with we manually open the both eyelids with our hand. For example, this is thumb, and ask the patient to close his eyes forcefully. And what will happen? The eye will move outward and upward. So this is the uh, Bell's phenomena. And when it is poor, there is a risk of exposure keratopathy after the ptosis surgery. The tear film should be inspected. A poor volume or unstable tear film may be worsened by ptosis surgery and should be addressed preoperatively as far as possible. So next is a simple congenital ptosis. It is very important. So many of the child present us with the simple congenital ptosis. Diagnosis: congenital ptosis probably result from the failure of the neuronal migration or development with muscular sequelae secondary to this. A minority of the patient have a family history. So what happens is basically the neurons that needs to go to the muscles are unable to migrate. So that is why the congenital ptosis develop. And what are the signs? Unilateral or bilateral ptosis of variable severity. One thing is very usually the congenital ptosis are mostly 75% of the time it is unilateral and severe, but it can be bilateral as well, with the variable severity. So it is very important to know the signs of the congenital ptosis. You can identify these signs and you will know that there will be the these are the signs of the upper congenital ptosis. So absent upper lid crease and a poor levator function. So that is why there is a lid crease absence and there will be the poor levator function. That is why the frontalis sling procedure is usually the procedure of choice in the cases of the congenital ptosis because of the poor levator function. In down gaze, the ptotic lid is higher than normal because of the poor relaxation of the levator muscle. This is in contrast to acquired in which the affected eyelid is either level with or lower than the normal on the down gaze. Following surgical correction, the lid lag in down gaze may worsen. So one thing is that there will be the lid lag in case of congenital ptosis. What is that? Basically, when you in the acquired ptosis, when you ask the patient to look down, the ptosis worsen in the down gaze. But in case of a congenital ptosis, when you ask the patient to look down, the lid remain at the same position because there will be the unable to relaxation of the levator muscle. So there is a lid lag, and after the surgical correction it may worsen. Association is the superior rectus weakness may be present because of its close embryological association with levator. Compensatory chin elevation in bilateral severe bilateral cases. Refractive errors are common and are more frequently responsible for amblyopia and then ptosis itself. So one thing very common that it is also the refractive errors are very common in the cases of the congenital ptosis patient. Treatment should be carried out during the preschool year once accurate measurements can be obtained and may be considered earlier in severe cases to prevent amblyopia. Levator resection is see below is usually required. A weak Bell's phenomena can result in a exposure keratopathy after ptosis surgery. So, I basically levator resection can be done, but usually I think the most common procedure usually performed is the frontalis procedure. So these are the cases of the congenital ptosis. A is showing mild right ptosis, B is showing the good levator function, C is showing the severe left ptosis with absent skin crease, and D is also showing the poor levator function. C is showing the bilateral severe ptosis, and F is showing the poor levator function. So Marcus gun jaw winking phenomena. It is a very common phenomena. Marcus gun jaw winking is basically the nerve that is supplying the pterygoid muscle is supplying the levator muscle. So what happens is when the mouth moves, the lid moves too. So that is why how it is connected. And the Marcus jaw winking is closely associated with the monoocular elevation defect as well. Marcus jaw winking syndrome about introduction. About 5% of all the cases of congenital ptosis are associated with the Marcus jaw winking phenomena. Most are unilateral, although the exact etiology is unclear, but it has been postulated that a branch of the mandibular division of the fifth cranial nerve is misdirected to the levator muscle. So the nerve that is supplying the mouth is supplying the levator muscle. Diagnosis: retraction of the ptotic lid in conjunction with the stimulation of the ipsilateral pterygoid muscle by chewing, sucking, and opening the mouth, or the contralateral jaw movement. Less common stimuli to winking include jaw protrusion, smiling, swallowing, and clenching of teeth. Jaw winking does not improve with age, although patient may learn to mask it. So, what is that happening is basically when the patient is using his mouth or that nerve is stimulated, the ptotic lid gets better and gets retracted. Treatment: surgery should be considered if the jaw winking or ptosis represent a significant functional or cosmetic problem. Because the jaw winking phenomena is usually masked by the patient, so masking effect is quite good. So sometimes the surgery is not necessary, but whenever it is causing a problem, cosmetic problem, you can do the ptosis surgery. So one thing about difference in the surgery of the Marcus conjaw winking is that what you do is, that a levator muscle is getting innervated, which is innervated by the fifth cranial nerve. So the levator muscle, which is supplied by the third cranial nerve, is supplied by the fifth cranial nerve. So what you do is basically you resect all that muscle. You resect all that muscle. Why? So that um, because the innervation is getting supplied by the fifth cranial nerve, you cannot do much about it. So you resect all the muscle so that that innervation is gone. And what you do is that you then do the frontalis sling procedure. You to improve the doses. Mild cases with the reasonable levator function of 5 millimeter or better and little synkinetic movement may be treated with the unilateral levator advancement. Moderate cases, unilateral levator disinsertion can be performed to address the synkinetic winking component with the ipsilateral blow frontalis suspension so that a lid elevation is due slowly to the frontalis muscle elevation. Bilateral surgery, bilateral levator disinsertion with the bilateral bro suspension may be carried out to produce a symmetrical result. So whenever there is a very mild ptosis like or a very little synkinetic movement, you can perform the levator resection, levator advancement procedure. But in case of the moderate and the severe ptosis, the procedure of choice is that you disinsert the levator muscle and then you do the frontalis sling procedure. We will discuss the surgery in the coming topics in the surgery. Third nerve misdirection syndromes. The third nerve misdirection syndromes may be congenital but are more frequently follow acquired third nerve palsy. Bizarre movements of the upper lid accompany various eye movement. Ptosis may occur following aberrant facial nerve regeneration. Treatment is by levator disinsertion and bro suspension. So whenever there is a trauma to the third cranial nerve, and when the third cranial nerve get repaired, the third nerve is redirected, means that it is having a bizarre moment. So what it's do, that there will be the ptosis in the eye, but it will get better on the side gaze or um, uh, side gaze, just like in the figure 2.55. Third nerve redirection. A is showing the moderate right ptosis and B is showing the retraction of the right lid on the right gaze. So what it is doing, basically there is a ptosis of the right eye, and when the patient looks on the side gaze, the lid gets retracted. So this is a third nerve misdirection. Involutional ptosis is basically the levator muscles get weakened, it gets stretched out, it gets disinserted. So that is why involutional ptosis occur. And one thing is important as compared to the congenital ptosis, that there will be the high upper lid crease in these patient, and the ptosis will be worsened on the down gaze. Involutional or aponeurotic ptosis is an age-related condition caused by the disinsertion or stretching of the levator aponeurosis, limiting the transmission of force from the normal levator muscles to the upper lid. Due to fatigue of the molar muscle, it frequently worsens towards the end of the day, so that it can sometimes be confused with ptosis secondary to myasthenia. There is a variable, usually bilateral ptosis with the high upper lid crease and a good levator function. So very important, the levator function will be the good in the cases of the aponeurotic ptosis. In severe cases, the upper lid crease may be absent. The eyelid above the dorsal plate is very thin and the upper D sulcus is deep. Treatment options include levator resection, advancement with reinsertion, or interior levator repair. So these are the kind of procedure that you can do with the levator. You can just resect the levator to increase its power. You can advance the levator, uh, and you can do interior levator repair. So this is showing the 2.56 is showing the aponeurotic ptosis. So you can see that there is a severe bilateral ptosis and there is a deep lid sulci, high upper eyelid crease, and which are giving us the signs of the severe ptosis. Tip involutional ptosis may be confused with ocular myasthenia gravis because it frequently gets worse towards the end of the day. Mechanical ptosis is the result of impaired mobility of the upper lid. It may be caused by dermatocolisis, large tumors such as neurofibroma, heavy scar tissue, severe edema, and anterior orbital lesion. So, mechanical ptosis is caused by due to the mass present on the upper lid. So, next is the surgeries of the ptosis. So first we have to understand the anatomy of the eyelid to know about the uh, how do we perform the surgeries. Anatomy. The levator aponeurosis fuse with the orbital septum about 4 millimeter above the superior border of the tarsal plate. Its posterior fiber insert into the lower third of the interior surface of the uh, mm, tarsal plate. The medial and the lateral horns are the expansion that act as a check ligament. Surgically, the aponeurosis can be approached through the skin or conjunctiva. So it is very important thing, because in case of the levator resections or levator advancement, levator aponeurosis is very important. So you must know the anatomy of it. So you can see this figure here, and it is showing us the levator aponeurosis. So these red fibers are the levator aponeurosis. You can see that uh, it's it attaches to the orbital septum uh, about the superior border of the so there was a mild disconnection in the lecture. So we were talking about the levator aponeurosis. So basically the levator aponeurosis in this case is red in color, lead in color, and it attaches to the orbital septum about, so in this blue one till here is a tarsal plate, and it attaches to the orbital septum about 4 millimeter above the tarsal plate, and its posterior fibers attaches to the interior side of the tarsal plate. So this is how the insertion of the tarsal plate orbicularis levator aponeurosis is. So and there is a molar muscle that is attaching above the tarsal plate, and in the lower case there is a tarsal plate, and the other is the lower lid retractors. The red one is showing the inferior tarsal aponeurosis, and this is the inferior tarsal muscle, which is analogous to the molar muscle in the upper lid, and it is also the this red one is the analogous to the levator aponeurosis. So this is the appearance of the Asian eyelids. The levator muscle aponeurosis fuses with the orbital septum about 4 millimeter above the superior borders of the tarsal plate. Its posterior fiber insert into the lower third of the interior surface of the tarsal plate. The medial and the lateral horns are the expansion that act as a check ligaments. Surgically, the aponeurosis can be approached through the skin or conjunctiva. So when you look at the interior surface or interior side of the aponeurosis, it looks like this. So these are the check ligaments, medial and lateral check ligaments with the levator aponeurosis. Eyelids of the Asian, the main difference in the upper lid appearance is the low or absent skin crease in about 50% of the Asian due to the lower insertion of the levator aponeurosis close to the lashes. The symptoms of also insert lower on the aponeurosis. The presence of the medial canthi fold can cause lash ptosis. Molar muscle is inserted into the upper border of the tarsal plate and can be approached transconjunctivally. Inferior tarsal aponeurosis consists of the capsulopalpebral expansion of the inferior rectus muscle and is analogous to the levator aponeurosis, and the inferior tarsal muscle is analogous to the molar muscles. So it is important for the treatment of the ptosis. So when we get to the treatment of the ptosis, basically the treatment of the ptosis depends on the two things. One is the severity of the ptosis and the other is the levator function. If the severity is mild and the levator function is good, then we perform the conjunctival molar resection. If the severity is moderate and the levator function is good up to 5 mm, then we perform the levator resection procedure. And if the ptosis is severe and the levator function is poor, almost less than 5 mm, then we do the frontalis sling procedure, or which is also known as bro suspension. So conjunctival molar resection, this involved the excision of the molar muscle and overlying conjunctiva with reattachment of the resected edge. The maximum elevation is achieved 2 to 3 mm. So it is used in a cases of mild ptosis with good at least 10 millimeter levator function, which include most cases of the Horner syndrome and the mild congenital ptosis. So you can see this figure in which that the area above the tarsal plate, which is usually the molar muscle, is resected along with the conjunctiva, and the edges after the resection is being sutured. So this is the conjunctival molar resection. It is done for the procedure with the mild ptosis and with the good levator function. Next is the levator advancement or resection. In this technique, the levator complex is shortened through the anterior or skin or posterior conjunctival approach. Indication include ptosis of any cause provided residual levator function is at least 5 mm. So for this procedure, the levator function should be at least 5 mm. The extent of resection is determined by the severity of the ptosis and the amount of levator function. So how much levator muscle you should resect depend upon the uh, amount of the levator function that is present. The predictability of the correcting height is the same whether an interior or posterior approach is used. However, the advantage of a posterior approach is predictability of the lid contour. So you can see figure 2.60. It is showing the anterior levator resection. What you do is you incise the skin, and after incise the skin, you incise the orbital septum, and then you retract the orbital fat, and the levator muscle is exposed. You dissect the levator muscle and then you resect the muscle, the amount you require to resect it, and then the rest of the levator muscle is then sutured to the tarsal plate. So this is how the procedure of the levator muscle is done. Interior levator resection: A is showing the skin incision, B is showing the dissection and the resection of the levator aponeurosis, and C is showing the levator reattachment to the tarsal plate. Next is the pro or frontalis suspension. It is used for the procedure in which there is a poor levator function and there is a severe ptosis. So how does it work? You know that a frontalis muscle can also elevate the lid. So what you do is you uh, use that function of the frontalis to hang to elevate the lid. You tie it with the tarsal plate, and whenever the frontalis muscle move, so with that movement the lid also move. So typical indication include the ptosis associated with third nerve palsy, blepharophimosis syndrome, and following an unsatisfactory result from the previous levator resection. The tarsal plate is suspended from the frontalis muscle with the sling consisting of the autologous fasciolata or non-absorbable material such as proline or silicone. So what you do is basically you suspend the tarsal plate with the from the frontalis muscle with the sling, which is a material which can be the fasciolata, which can be the proline, or which can be the silicone. And so this function will help us to retract the eyelid with the function of the frontalis. So this figure is showing us the pro suspension procedure. A is showing us the site of incision. So basically the incision site are at the medial and the lateral limbus in a cases of along the eyelid margin, and in the eyebrow it is usually at the medial and the lateral canthi, and the pentagon and the other one is at the mid of the eyebrow above the eyebrows. So you, what you do it, you suture that, you pass the sling through the tarsal plate, then through the eyebrows, and then you tie it and the above the eyebrow. And that is how it works, that after the procedure, when you frontalis action is used to elevate the lid through the tarsal muscles. So that's it for the ptosis. See you in the next lecture.